Thank you for joining us for this exciting session titled, Are We There Yet? An update on psychedelics in psychiatry. It is my distinct pleasure to introduce our next speaker, Andrew Penn. Andrew Penn is a clinical professor at the University of California, San Francisco School of Nursing. Please remember to type your questions in the Q&A box to the right of your screen and upvote your favorite questions. Our faculty will respond to the most upvoted questions during the upcoming panel Q&A session. So without further delay, let's begin the presentation.
Hi, I'm Andrew Penn. I'm a psychiatric nurse practitioner and a clinical professor at the University of California, San Francisco, in the School of Nursing. I'll be talking about updating you in psychedelics here. These are my disclosures. And really, this talk is intended to bring people who have some familiarity with psychedelics in psychiatry up to speed about current developments. So I'm not going to get too much into the mechanism of action or the background, assuming that you know something about that, and really talk about some of the current controversies and ongoing research into this fascinating development in psychiatry. So, as you may know, it was a really big year in 2024 for psychedelics. The first Journal of the American Journal of Psychiatry, first issue from 2025, was devoted entirely to psychedelics. And this comes on the heels of some big news in the FDA space with the rejection of the new drug application that Lykos put in for MDMA assisted therapy for PTSD, which then led to some significant shakeups within Lykos and their originator, MAPS, the Multidisciplinary Association for Psychedelic Studies, and then ongoing questions about what comes next. And I'll talk a little more about that. Other entities that are developing psychedelics, such as Compass, also reported some setbacks in their phase 3 work. And there's been, not surprisingly, a lot of mergers and acquisitions in this space as well, as smaller startup companies are being acquired by larger pharmaceutical companies, some legacy pharmaceutical companies getting interested in this space as well. And then the big question of what is the dose of psychotherapy that's needed to be combined with these psychedelic drugs to be effective. Starting to get into some federal funding for psychedelic research, which is a change from historically philanthropically and private foundation funded and venture capital. And then the big open question, as I'm recording this at the beginning of 2025, which is where will the federal government go on this particular topic? So psychedelics is a big topic, and we can only talk about some small parts of it here. But I'm going to focus primarily today on the medicalization aspect and talk a little bit about places where people are using psychedelics outside of medical clinical use. But that's will be the limitations of my talk today. So here we are at the beginning of 2025, and there's an interesting fork in the road that we seem to be facing. One of which really focuses on the use of psychedelics within medical treatments, and this includes the question of how much therapy does somebody need to combine with the psychedelic, even development of drugs that are related to psychedelics, but are not necessarily causing a psychedelic experience. And then in the other direction, we have more use in what might be considered decriminalized settings or in religious contexts. So we'll talk a little bit about both of these today. I think it goes without saying to this audience that there are a lot of people that have unmet clinical needs, so I'm not going to belabor that point. But a recent paper that came out found that there's over 5 million people in the United States who might benefit from psilocybin treatment for depression using the criteria that were used in clinical trials. So it's a lot of people that could potentially benefit from this work. And just to be clear what drugs we're actually talking about, I'm primarily going to focus on MDMA, psilocybin, which is the prodrug for psilocin, LSD, ibogaine, dimethyltryptamine or DMT, and 5-methoxy-DMT in my talk today. We already have a couple of drugs that have psychedelic-like effects, which would be ketamine and S-ketamine, which are already available and in clinical use. So I'm not going to spend too much time talking about those today. Just a brief overview of how psychedelics could be therapeutic. If you want to learn more about this on my YouTube channel, I have a more extended conversation about mechanism of action. But essentially, of course, like all of our treatments, a drug is ingested, it causes changes at the synapse, And that causes larger brain changes. And there's a number of working hypotheses, probably with significant overlap, one of which is known as the entropic brain hypothesis, which posits the idea that psychedelics change the way that the brain talks to itself during the period of acute drug effects. And that has sort of a resetting effect after the drug wears off. Additionally, many of these drugs they cause plastic events within the brain. They're psychoneuroplastogens. They can be thought of by activating things such as TRPB receptors, cause neurons to grow and to branch out to other neurons. Um, an interesting model found in animals that psychedelics may transiently reopen periods of learning. So that in rat models, this has been identified as a social learning window where rats learn from other animals. Not clear if this translates to humans, but it's a provocative finding. With MDMA in particular, we see decreases in activity at the right amygdala. So people are more able to talk about their traumatic events in therapy. And related to that, psychedelics also seem to allow a reduction in experiential avoidance. And this is something we see a lot in many psychopathologies, particularly depression and PTSD, where people actively spend a lot of energy avoiding thinking about difficult things. And psychedelics tend to kind of invite an exploration of those difficult emotional experiences. And then finally, this is one that probably gets the most press, is really people taking a moment to rethink their own story, their own narrative, perhaps what effect trauma has had on their lives, or the way they go about the world as somebody who has depression. But it's probably a combination of all these things that lead to this kind of therapeutic response that we see. Now, there's a lot going on in the psychedelic development space, and I want to be clear that a lot of what I'm going to talk about in the next few slides is really early data. These are what are known as top line findings. These are not necessarily published in medical journals, but these are in the form of press releases from companies that are developing many of these compounds. So, a lot of this will probably change over even the year that this video will be active, and I'll be happy to talk about the ensuing developments that have occurred in our live Q&A session. But the way you read this chart is anything at the center has already been FDA approved, and you see there's only one drug there, which is Spravato, which has an indication for depression. Many other things starting to close in on phase 3 trials, late phase 3 trials, and then a whole host of early candidate drugs in either early clinical or preclinical stages of development. Now, the big news from 2024, which was surprising to some and a disappointment to others, was the decline by the FDA of Lykos's application, new drug application for methamphetamine, which is the technical term for methylene dioxymethamphetamine or MDMA, for the treatment combined with psychotherapy for PTSD. So this has been long in development. It got breakthrough status in 2017 at the beginning of phase 3 trials. There were 2 phase 3 trials which were published, and then it went to the new drug application process in the end of 2023. It was reviewed by an FDA advisory committee in June of 2024. A long meeting. It's publicly available if you want to sit through it, but a really interesting long comment of a public comment period. And then that advice went to the larger FDA, who returned a complete response letter in August of 2024, not outright denying the application, but saying they needed more data. They wanted an additional phase 3 trial. So the advice that was given to the larger FDA was asking the question of if this treatment was based on the available data, if it showed that it was safe and effective, and the advisory committee, for the most part, said that they did not feel that it was. So what happened during that advisory committee? And we don't know exactly what was in that complete response letter because that's not open to the public. Only the FDA and the drug sponsor get to see that. But a number of different things were highlighted in the advisory committee meeting, one of which was fairly basic stuff like not collecting pre and post dosing, liver, and cardiac measurements. And then this question of, well, what is the therapy? So if this is a drug plus therapy, what is the actual therapy? Now, MAPS had a manual, MAPS and Lykos had a manual, which they instructed clinicians how to use that. But there was critique that the manual was somewhat non-standard. It wasn't a evidence-based psychotherapy, and it wasn't clear how much of the effect and the outcome of these subjects that went through the study was the result of the drug and how much of it was the therapy. Additionally, there was doubt cast on the what would be considered the equipoise of the clinicians. Did the clinicians approach this with too much enthusiasm, and did that lead them to underreport adverse events? And even how do we define an adverse event in psychedelics is tricky because, if you think about, say, a patient who has really bad PTSD and depression, who has not laughed in years, and in the middle of an MDMA session, they are laughing, is that an adverse event or is that a therapeutic event? I personally would rather that we just define these as changes from baseline and take that adverse decision piece out of it, but just report what changes from the beginning of the study to the end of the study. But nevertheless, this concern about what was considered an adverse event and were they sufficiently reported was raised. There was a very unfortunate situation in early phase 2 studies, not the phase 3 study that was given to the FDA of sexual abuse by a researcher of a subject, which is disgraceful and should never have happened, but did actually understandably raise a lot of concern by the advisory committee. And then this question of functional unblinding, and we'll talk about that more here. So a lot has happened in Lykos since then. Obviously, they don't have any other drugs to fall back on. They have a one molecule in their portfolio, and so this has created a big shakeup. As you can imagine, a lot of the staff were laid off. There's been shakeup in leadership. Folks from the Spravato effort from Johnson & Johnson were brought in as medical advisors, and this question of how are they going to pay for another phase 3 trial, which would probably run about $100 million. At the time of this recording, there's movement afoot to possibly take the Lykos organization back over from its investors by a private investor. All of this has really resulted in uncertainty for MDMA. I think it's likely that it will get back to the FDA for consideration again in the future, but that's probably not going to happen for at least 2 or 3 years. Now, one of the questions that the advisory committee brought up was this kind of obvious question, that people tend to know when they've been given a psychedelic versus a placebo. This should really not come as a surprise to anybody. In fact, it was even sort of satirized in this New Yorker cartoon. So this question of what's known as functional unblinding, do you know that you got the drug or not? And, psychedelics honestly are sort of subjected to a higher standard of evidence in some ways, because it turns out that the vast majority of medication trials do not assess for functional unblinding in psychiatry. In fact, less than 4% actually have even asked that question when looking at many, many studies. And the most recent FDA approvals in the antidepressant space did not ask for that data. So dextromethorphan, bupropion, esketamine, and zuranolone were all brought to market without assessing functional unblinding. And it turns out when you do actually assess for functional unblinding, what people think they got actually has more bearing on their outcome than the drug or placebo assignment. So psychedelics, not surprisingly, are difficult to blind. And that introduces doubt of is that why people got better? Is they felt a drug effect or they didn't feel a drug effect, and that then colored the way they reported their symptoms going forward. Now, this is really interesting data coming from a different study. This is a phase 3 study run by a company called MindMed looking at LSD treatment for generalized anxiety disorder. And what was fascinating about this is, unlike the MAPS study, which only had 2 treatment arms, they had a drug and they had a placebo treatment arm. This particular study used 5 different assignment conditions. So you could either get placebo, a low dose, 25 micrograms of LSD, a moderate dose, 50 micrograms, or a full dose at 100 or 200 micrograms. And what you can see here in this chart, so I know it's a little hard to read, but taking a look at number 3 and number 2, those are the low arms, and number 1 is the placebo. And they also asked about functional unblinding. So what was interesting is that about a third of people who actually were assigned to placebo thought they got LSD, which is intriguing. At the 25 microgram, that very low dose, the vast majority, 87.5% of people said, yeah, I think I got LSD. At 50 micrograms, almost 100% guessed correctly. And at the full dose, everyone guessed correctly. So, not surprisingly, people tend to know when they've gotten LSD or not. But what's interesting about this is when you look at the outcomes. So, it's only the people that got the full dose, the 100 or 200 microgram dose, that really dropped their Hamilton anxiety rating scales. Whereas the people that got the moderate dose, they knew they got the drug, but they didn't have that reduction in symptoms as much as the people who had the full dose. So, what this really tends to kind of point out is that not only might LSD help generalized anxiety disorder, which is fascinating in its own right, but also that the dose really matters, and it's not that sort of giveaway of which group you've been assigned to that makes the change. And this is also advancing through phase 3 trials. There's a second phase 3 study that is expected to be showing results in early 2026. Now, there's this other question of how much therapy do we actually need to give along with the psychedelic? The early studies used a lot of therapy, 40, 50 hours of therapy. Some of the newer studies, such as the MindMed study, had very minimal therapy. In fact, they had no therapy. They had somebody sitting with the person, but not delivering psychotherapy. There was no psychotherapy before or after. So there's that question of what is the minimal effective dose of psychotherapy for this to work? Is it 0? Is it a few hours? Is it many hours? And then if there is going to be psychotherapy, what kind of psychotherapy needs to be delivered? Should it be an evidence-based psychotherapy such as cognitive processing therapy or exposure therapy in PTSD or CBT in depression? Or should it be one of these more tailored to psychedelics kind of treatments, such as the Embark model, which they're using in the Psych trials, which I'll talk about in a moment. And the big question of, look, Andrew, you've been talking about this for the better part of a decade now. When is this actually going to be available? And I'll remind you that ketamine and esketamine are available now. They're being used now. Psilocybin is probably the next thing out of the gate for treatment-resistant depression. And then there's these things that are further out in clinical trials that are a little too early to tell. Now, there's already been a number of phase 2 studies there's been 2 large phase 2 studies that have been published. This is the COMPASS study, came out in 2022. This is for treatment-resistant depression. And you can see the significant drop, particularly, and also a dose-related significant drop. The 25 milligram group did better than the 10 or the 1 milligram group in this study sponsored by COMPASS. They are currently working on phase 3. It's taking a little longer than expected. There were some setbacks in that process, but we're hoping for results from the phase 3 trials at the end of 2025. Additionally, USONA worked on a study. I was part of working on this study where we compared 25 milligrams of psilocybin to a active placebo of niacin. And again, you can see this large separation in this phase 2 study, which has now moved on to phase 3. So let's look ahead to what's coming up in the future. So another very provocative and interesting idea is the use of psychedelics for the treatment of substance use disorders. So this particular study is noteworthy for a couple of reasons. One is that it's one of the first federally funded studies. As I said before, most of these things have been funded by philanthropic and foundation money. This is coming from NIDA. This is a grant to NYU, Michael Bogenschult's group, to study psilocybin for opiate use disorder. Fascinating study. We'll use 3 different doses of psilocybin randomization, fairly large study, 240 folks, and they're going to have a long follow-up. They're going to follow these folks for 6 months, looking at opiate use as confirmed by urine drug screens as their primary outcome. So follow this one, definitely fascinating. Another interesting study is using deuterated oral psilocin for major depressive disorder. This is being conducted by Cybin. Uh, Deuteration, as you recall, is the substitution of a hydrogen molecule for a deuterium molecule. What that does is it allows the drug to have a larger area under the curve. So the drug comes on more slowly, it lasts longer, it gives you more time to do this sort of to spend time in that non-ordinary state of consciousness. Early studies, top-line results, again, not published, looking at moderate to severe major depression, showing these significant drops at the 3-week endpoint and sustaining for 4 months, with the higher dose folks still in remission at about 75% at 4 months out. So this did also get FDA breakthrough designation and will continue on into later stage trials. Another deuterated molecule, this time dimethyltryptamine. So DMT historically is something that is inhaled, and it typically is a very short acting drug on the order of 10, 15, 20 minutes. So deuterating this and putting it into an IM form, as they've done in this particular study for generalized anxiety disorder, again allows for a longer period of exposure to the drug. Looking at this for generalized anxiety disorder, this is a 2-dose protocol using an IM formulation of the drug and using the Hamilton as their primary outcome. There's another company, Atai, that is looking at this as a buccal film version of DMT. It's not deuterated. That's in phase 1 trial, so just looking at pharmacokinetics at this point. A sort of a related but different molecule is 5-methoxy dimethyltryptamine, or 5-MeO-DMT. Also, typically a very short-acting, typically a smoked or inhaled drug. And the indications for this, there's 2 different companies looking at this for major depressive disorder, postpartum depression, which I think is particularly interesting, and alcohol use disorder. So this is Beckley, and GH Pharma is looking at this. Beckley has already done a intranasal DMT delivery system, so that is in phase 2. Again, they've looked at this for the relapse prevention of alcohol use disorder in combination with CBT, looking at reduction of heavy drinking days and also measuring abstinence. GH Pharma in Europe has also an inhaled version of this drug that they are looking at for indications of postpartum depression, treatment-resistant depression, and bipolar 2 depression. Also have released very recently some top-line data showing, again, significant reductions in the MADRS just a few days post-treatment. So these all sort of fall in the category of rapidly acting antidepressants. Ibogaine is an interesting, this is a plant that originates in West Africa, has multiple areas of activity, multiple mechanisms of action. It is a glutamatergic drug. It also works on kappa and mu opioid receptors, in addition to alpha 1 and alpha 2 noradrenergic receptors. It works on acetylcholine nicotinic receptors and also serotonin and dopamine transporters. And finally, also induces BDNF and glial-derived neurotrophic factors. So again, part of this idea of these neurotrophic drugs. It can be a little bit tricky to work with, has a long duration of action. The acute effects of the drug last about 8 hours, and then there can be kind of a residua that can go on for a day or two. So it creates some real challenges in terms of using this in a clinical setting. And historically, one of the concerns about ibogaine is the risk of prolongation of the QTC with the heart. There is some early investigation of this as a treatment for opioid use disorder, and Nolan Williams at Stanford did an interesting study where ibogaine is a Schedule 1 drug, so they would actually have their population was special forces veterans who would be prepared, do their preparation and integration work at Stanford, but then would go to a clinic in Mexico where this is legal to be treated with ibogaine, looking at outcomes of PTSD, overall disability, depression, and anxiety, again, showing significant drops in all of those, and we're able to mitigate that cardiovascular risk by pre-administering with magnesium, which prevented any adverse cardiac events. And then there's this big question of, do we even actually need to have the psychedelic experience in order for benefit to occur? Some people have called these parapsychedelics or non-psychedelic psychedelics, and one of the companies that's developing these is known as Delix. And essentially, what they're attempting to do is to create that neuroplastinogenic effect of spine density growth and synaptogenesis to happen rapidly without incurring that sort of non-ordinary state of psychedelic consciousness. They have a couple of compounds in early phase one development. And there has been a number of small companies that have been acquired by larger legacy pharmaceutical companies with these portfolios of early stage molecules that may or may not have psychedelic subjective effects, but looking at those to see if they might have some of these salutary antidepressant effects. The cost of this treatment is really a big question and concern, especially if we're looking at a treatment that requires a lot of psychotherapy, a lot of personnel treatment, but even the cost of the drugs here. So, this is a paper that recently was released looking at the projected cost of something like MDMA and suggesting that it might cost as much as $36,000 for the 3 doses of the drug, and then you calculate in another 12,000 or so for the psychotherapy labor, and we're looking at a total cost of about $50,000 per patient. Now, in oncology, $50,000 is not a lot of money. In psychiatry, $50,000 would be a lot of money. So this really potentially has the possibility of limiting access to this if this is a really expensive treatment that people are not able to access. So, looking at different ways that those costs might be mitigated, one of which is asking the question if we actually need 2 therapists for the entire treatment protocol. There's been a number of different labs that have been working with different ways of working with this. Many ketamine clinics don't have 2 therapists in the room. In fact, most psychiatric treatment doesn't have 2 therapists in the room. So this question of do we actually need 2 people to be there the whole time is an active question. And interestingly, in naturalistic psychedelic use, so such as ayahuasca circles and such, these are often used in group settings. And this open question of could we actually utilize the group to maximize the therapeutic benefits and also reduce costs is an important question. So, with all treatments in psychiatry, we need to think about matching the treatment to the specific patient. With psychedelics, it's really no different. There may be some people who really can probably do just fine with minimal psychological support. I'm thinking about people that maybe are going through a challenging health diagnosis. There's been a lot of interest in can we use psychedelic treatments in palliative care. These might be people that don't have a lot of psychological comorbidity that just need some gentle support. And then going all the way to the right of this spectrum, some of our patients that are probably going to need a lot of care and containment in order to benefit from these treatments. I'm thinking about people maybe with complex PTSD or borderline personality disorder who might incur harm if they're not well contained in these, what can be very powerful emotional experiences. One of the proposals that I've put forth as a way of mitigating some of these costs is really thinking about playing to the strengths of each profession. So, as you know, I'm trained as a nurse, and I think about a lot of the things that nurses do kind of naturally with patients, thinking about presence, thinking about providing care, thinking about taking care of the whole body, are really well matched to a psychedelic, sitting for somebody with a psychedelic medicine. The psychotherapy part might be better done by a psychotherapist. So in this model, we talk about the preparation and the integration, which are don't have drug involved, would be done by a psychotherapist, and the dosing itself would be done with a nurse and perhaps an assistant. And this cycle, if it needed to be repeated, following treatment team correlate conversation could then be repeated as is indicated by a protocol. So the other place we're looking at this sort of fork in the road here is um, we've got one side where if we have FDA approved treatments, then there's a higher probability that people will be able to access this through use of their insurance. So whether that's commercial insurance or Medicare or the VA, more people will be able to get these treatments approved and paid for if there's an FDA approved drug, which also probably increases the safety and the regulation of that practice. But on the other hand, what we're seeing more of is this sort of decriminalization model that's being done outside of the medical model. We see a couple of states, Oregon and Colorado, that have created some legislation around this, and there's a number of smaller municipalities that have done as well. Now, the downside to this is that most people won't know how to access these kind of care, and if they do, they'll have to pay for it with cash. And in many instances, the regulation is outside of the regulations that we have as medical providers. Now, this is often presented as sort of an either or question. And what I see sort of naturally evolving is that it's a both and. So what's already happening in a number of states is that we have these, as I mentioned, Oregon, Colorado. In Colorado, starting this year, you'll be able to go to a provider who can treat you with something like psilocybin, or you can go to a healing center. In Oregon, they specifically made this non-clinical, so it's known as an adult supervised experience. You can go to a psilocybin service center as an adult and experience psilocybin. They're specifically not supposed to offer clinical treatment, which sometimes I've noticed gets a little bit murky, but these are two states that have already moved ahead of the FDA, and a number of other states and municipalities are considering this. There have been some setbacks in Massachusetts just this last fall. The voters rejected question 4, which would have legalized psychedelics there in Massachusetts. And in my state of California, a bill that came before the governor was vetoed, which would have had a similar outcome. Another area where we're seeing more of this use outside of clinical treatment is in what's known as religious freedom use. So there is a law known as the Religious Freedom Restoration Act. It was signed by President Clinton back in the 90s, which allowed for the Native American church to use peyote, which had been a sacrament for centuries, to be able to use that freely without risk of legal persecution. What has happened is that a number of organizations have declared themselves as psychedelic churches and offer various psychedelic compounds, typically psilocybin, as a sacrament. And this really speaks to not only the medical change which people desire, which I've spent most of this time talking about, but also the other reasons why people sometimes are interested in psychedelics, which would be for more spiritual change. And there's been institutions such as Emory, which have opened their Center for Psychedelics and Spirituality to try and examine this very question. And then the wild card thrown in all of this is what is happening with the federal government. The newly appointed HHS Secretary, RFK Jr., has broadcast his interest in psychedelics and an interest in changing the way that research is moved through the FDA. It's unclear what that will actually operationalize as, but this is at the same time that the current president has talked about wanting to crack down on drug dealing, on drug trafficking. So it's really unclear how this is all going to sort of shake out. And at the same time, we're starting to have federally funded studies for psychedelics and increased interest within the VA. So all I can say to this one in the beginning of 2025 is stay tuned. Things are likely to change, and we can talk about that in the Q&A. So, in closing, while we did have a significant setback with the decline of MDMA for PTSD in 2024, there's a lot of other compounds that are moving through clinical trials. And this question about functional unblinding, that may not be the reason why people get better, but it is important when we structure these studies to have different dosing steps so that we can begin to tease that out. Is it the unblinding that makes people feel better, or is it the actual drug effects themselves? And increasingly, we're seeing this split between the medical use of psychedelics and more naturalistic use in decriminalization and religious freedom settings. So that's where we stand in early 2025. If anything's likely to change, it's this topic, and I look forward to talking more about it in the live Q&A. Thanks.